Hello, my name is Sherry Triff, and I'm a dental hygienist. I apologize for being unable to be present today due to a conflict of time with another course. Carol Reed, a Metro State nursing professor, was my mentor for the capstone project. The following presentation is an educational tool for the nursing students at Metro State and for public health nurses. I believe the students and nurses will use this presentation and find it useful for learning about oral health care for pregnant women and children. I hope you enjoy the presentation. Maternal and Pediatric Oral Health Care. Here's a quote to keep in mind during the presentation by Benjamin Franklin: "An ounce of prevention is worth a pound of cure." The objectives in this presentation is to become familiar with the history of dental hygiene, also explore development of caries prevention, and understand the importance of oral health for pregnant women and children. You'll be able to describe and identify early childhood caries and develop an understanding how maternal and children's oral health care needs collaboration between dental and medical professionals along with communities. Many researchers agree early childhood caries, ECC, is the number one disease in children. Dental caries, also known as cavities or decay, is caused by bacteria attacking the hard outer enamel layer of a tooth. ECC is 5 times more common than asthma and 7 times more common than hay fever. Numerous studies show that by the time of tooth eruption or shortly after, the importance of dental exams are prudent in preventing oral health diseases. Early interventions through dental examinations or screenings cut costs by reducing emergency room visits, with sources stating 25% of children from the age 2 to 4 are experiencing decay. Early interception and prevention plays a vital role in oral health. From the initial field of dental hygiene, children's oral health has been a concern to the public health programs emphasizing dental education. A national issue has been raised to the high rate of decay experienced in children. Therefore, oral health literacy needs to be communicated to children and mothers through a combined approach utilizing dental hygienists and other healthcare professionals. Looking back on the history of dental hygiene, we learn from the past and make strides towards the future of oral health. In the late 1800s and early 1900s, medical health inspectors screened school children and found that 90 to 95% of the children had untreated dental decay. During this period, Dr. Alfred Fones saw the oral health needs in his own clinic and began to train his dental nurse, Irene Newman, to perform dental cleanings. Dr. Fones experienced hesitation and fear of failure to have his patient's treatment done by a woman. However, he believed by delegating dental cleanings to a trained hygienist, it would allow him more time to treat other oral health care needs of his patients. Out of these concerns, a new branch of dental professionals, dental hygienists, were developed in the field of dentistry. In 1913, Dr. Fones opened the first dental hygiene school. After graduating, dental hygienists practice their profession by performing dental cleanings at schools while emphasizing oral health to school children. When 5 years of oral health prevention passed, Dr. Fones noted decay and communicable diseases declined and academic performances increased. As a result, school dental clinics developed. Today, dental care is taking another leap with leaders like Dr. Suzanne Beatty and Dr. Colleen Brickell, as they've pioneered a way for an additional delivery of dental health through advanced dental therapy. An ADT degree educates a dental hygienist to perform advanced dental procedures with a Master's of Science in Advanced Dental Therapy. A reflection upon history helps deepen an understanding in today's need for dental prevention and access to treatment. In 2000, Surgeon General David Satcher published a document to report the low public oral health literacy. The issue of oral disease remains a nationwide concern. Caries experienced in children can affect their overall health if left untreated, lead to additional caries, and disturb their psychological well-being and concentration in a classroom setting. Minnesota has taken steps to evaluate the state's oral health needs through screenings, treatment, prevention, and education to improve and access the state's dental needs. ECC, also known as nursing bottle tooth decay, is defined as non-cavitated and cavitated lesions, filled or missing teeth due to caries. Non-cavitated lesions are incipient or initial signs of decay found along the gum line. You can see the chalky white surface found along the gum line. Decay is when the incipient lesion has penetrated through the enamel layer, and the fourth picture shows rampant, more severe decay. Minnesota Department of Health published a document in 2013 stating dental caries is the most chronic childhood disease. According to MDH Oral Health Program, the socioeconomic status and level of oral health literacy greatly affects ECC. Studies have found that socioeconomic status links ECC by affecting dental care access, oral health importance, dental literacy, and stress levels. A basic screening survey reported that in 2010, 53% of 6 to 8-year-olds experienced decay, short 2 percentage points from the national average. In the Minnesota third grade population, 18% had untreated decay compared to the national average of 29%. MDH reports schools with 75% of children on the free and reduced lunch program were twice as likely to have decay. The population reflected children from low-income families and children of color had a higher decay rate. Intercepting the decay process with the early childhood and parent education is needed for oral health prevention in children. Now that you have a brief background and history of oral health, along with today's national and state statistics of ECC, we will turn our focus on components of prevention: fluoride, sealants, and education. A brief look back in the past explains the initial discovery of today's use of fluoride. In 1931, a discovery was made concerning the highly stained teeth in Colorado water. However, the stained teeth were caries resistant. The finding led towards experiments by Dr. Frederick S. McKay to find a suitable dosage of fluoride to add to drinking water. The dosage of fluoride, 0.7 to 1.2 parts per million, is adjusted according to the region's climate. Due to temperature and water intake, climates in the north will have less parts per million, while climates in the south will have more. According to the Center of Disease Control, water fluoridation has been one of the 10 greatest public health programs in the 20th century. In recent years, however, water fluoridation has become a controversial topic. The National Cancer Institute endorses water fluoridation, finding there is not a link between cancer and water fluoridation. People challenge water fluoridation, claiming children are getting enough fluoride from toothpaste and/or mouth rinse. In contrast, 60% of children continue to experience dental caries. It is estimated that $38 of dental treatment costs are saved for every dollar spent on community water fluoridation. Municipal water fluoridation is an important public health program based on scientific evidence. With water fluoridation documented safe and effective, it is important to incorporate fluoride for caries prevention to meet Surgeon General goals. A standard protocol during a dental cleaning is fluoride varnish. Additional fluoride application opportunities in medical clinics are unfolding. It's a simple procedure of swabbing fluoride varnish during a well check. Fluoride delivery through water fluoridation and topical application help in combating caries rate on smooth surfaces of teeth. Sealants are the second component in oral disease prevention. In order to protect the grooves and fissures located on the biting surfaces of teeth, a special plastic resin called dental sealants can be applied. Dental sealants help stop bacteria from nestling into the grooves of teeth, shielding the tooth from decay. Sealants are an important preventative procedure that's most commonly treated on the first and second permanent molars. When sealants and fluoride application are combined with oral health education, a thorough model of oral disease prevention is achieved for children. The third component in oral disease prevention is education. School performance and psychosocial well-being are affected by oral health status. Therefore, it is important to start oral health education early with parents and/or caregivers in order to prevent dental caries. 25% of children ages 2 to 4 experience dental caries, an increase of 30% compared to 20 years ago. Several factors play a role in increased caries possibility. Socioeconomic status is the biggest risk factor. Other factors include diet, drinking water, and habits. Each patient has a different exposure that affects their oral health. Individual risk factors may include children with special health care needs, such as decreased salivary flow, poor enamel formation, decreased dental access, and those who suffer from asthma. Taking considerations towards socioeconomic status and individual risk factors complete an assessment for education delivery. Screening forms. Using a dental screening form is an easy way to assess a mother or child's decay risks. The screening form is subdivided by low, moderate, or high risks. By gathering organized information, a health professional is able to better assess the preventative needs for each individual patient. Oral health assessments. Oral health assessments allow education for each individual patient. Dental screenings assess the oral health of a pregnant mother. Most infants and children acquire decay-causing bacteria from mothers. Mothers' existing dental decay and the bacteria can be passed down through saliva sharing. Examples of saliva sharing are a child eating off the same utensil as a mother, or cleaning a dirty pacifier by placing it in mother's mouth and then into child's mouth. By maternal educating, pregnant mothers receive oral health information that leads to a healthy start for her unborn child. Finding a dental home for a mother and her child provides care from the oral health professional. Pregnant women should avoid unnecessary treatment until after delivery. Some women may have a chief concern of a toothache. Instruct women on safe oral health care. Limited radiographs may need to be taken. Also, pain medication and local anesthetic may be administered. Urgent care should be treated in pregnant women. It is important that a pregnant woman receives dental care during her pregnancy. Periodontal health status is also assessed, as studies link active periodontal disease to premature deliveries. Once assessed, a mother's caries risk can determine adjuncts for home use, such as fluoride rinses, prescription fluoride toothpaste, and xylitol gum. Promoting a mother's good oral hygiene habits, such as brushing twice a day, flossing daily, and a lowering sugar intake, together provide an excellent home care and display a leadership role model for the children. Integrating oral health in prenatal classes collaborates dental and medical health care. With oral hygiene instruction, responsible steps are taught to mothers, leading to a decrease in ECC. Screening children. A child's screening includes caries risk assessment, fluoride application, and oral health education. Commonly for young children, the clinician will sit knee to knee with a parent in order to perform a lap exam. It is suggested that after milk consumption to wipe baby's gums with a soft cloth. A soft toothbrush is recommended after tooth eruption. Because fluoride is well documented as safe and effective caries prevention, it is suggested a rice size or smear fluoridated toothpaste to be used for children under the age of 2. For age 2 to 5, a pea-sized dose is applied to the toothbrush. Since sugar adds to future decay problems, sippy cups with juice, milk, or other sugary liquids are discouraged due to the frequent drinking of these liquids expose teeth to sugar. The American Academy of Pediatrics recommends only 4 to 6 ounces of juice a day and delivery of juice from a regular cup. An oral health approach combining hygiene, fluoride, sealants, and nutrition aid in preventing caries. Delivery of oral health education and prevention. Several programs advocate dental health. This is important because a simple repair of a tooth does not mean a future decay won't happen again. Public health nurses, WIC, Head Start, public health clinics, and school-based sealant programs all are wonderful resources for dental disease prevention. School-based sealant program. High-risk areas in Minnesota have also been part of a school-based sealant program funded by the CDC and Health Resources Service Administration. The program targeted 6 to 9-year-olds who were at the highest risk for dental disease. A screening form was utilized to attain the goal. The goal is to target this population and apply at least one permanent molar with a sealant. As the need for access to oral health care raises, avenues are being explored in developing oral health care access to a variety of branches through clinics, churches, and other community efforts. Hennepin County Medical Center and Whittier Clinic deliver oral health care to maternal and pediatric patient populations by staffing dental professionals. A dental hygienist provides education, fluoride, and screenings to access care for patients under and uninsured. By incorporating a hygienist into the facility, like Whittier Clinic, patients have access to dental care. The goal of the screens is to have a healthy mom and a healthy child by giving patients the resources to do so. Discussion. By applying preventative components, dental access to patients, and collaborated healthcare, achievable effects will attain oral health literacy.